Hey, everybody. We're really glad that those of you who are joining us live were able to make it, and those of you who are watching the recording found some time to listen in and hear about this new multidisciplinary clinic that we're super excited about. Both Leah and I were out there in April to open the clinic and had an amazing time meeting all of the clinicians who are involved in the care at this clinic, and really left inspired and super excited about the work that Dr. Abbott is doing with all of her subspecialists that come in and give really specialized attention to our kids. So we couldn't be happier to have this opportunity for her to share her vision. And it really is her vision that came together here to make this happen. And Children's Colorado has a history of building really powerful multidisciplinary clinics that Megan is building on here. So there's a lot of years of experience behind this. And we're just thrilled to get going here. Leah, do you want to say anything before we kick off?
No, you did a great job, but I do want to say that I loved coming to the opening day. That was like the highlight of my Q1 so far. Getting to meet all of the providers, and it's truly a collaborative effort. I can't wait to bring my own son to Colorado for this clinic.
Yeah. And I'll quickly add that many of you may not have seen a lot of this SCN2A, SCN8A coming together yet, but I think we're going to be seeing more and more of that. And Dr. Abbott can speak to this too about the true synergies there are between these disorders, a lot of similarities, and we truly believe that what we're learning from 2A will help 8A and vice versa. So we're excited to kind of launch this clinic with that in mind. And I'm going to hand it over to you, Dr. Abbott.
Yeah, thank you so much for that amazing introduction. I'm so excited to get to kind of be here tonight with all of you guys to talk about something I'm super passionate about, which is our multidisciplinary clinic for SCN2A and 8A. In terms of structure, I was going to talk a little bit about myself and how we got the clinic started, and then use these slides to go through clinic structure. And then we can speak to some of those reasons why 2A and 8A came together to make this happen. And then I wanted to leave a lot of time to answer questions and have this be interactive. So feel free to stop me as I go and ask any questions you guys have, and I'll try to be paying attention to the chat as well as we go. Um, but a little bit about me. I'm Megan Abbott. I'm a pediatric epileptologist and neurologist at Children's Hospital Colorado. I did my training at Colorado, doing my residency and fellowship, and was able to train with remarkable people, including Dr. Scott Demarest and Dr. Tim Banky, on caring for children with neurogenetic conditions, including SCN2A and SCN8A. They both have a lot of experience setting up multidisciplinary clinics for other disorders, including Rett syndrome and STXBP1. And I got to build off their incredible models to create this multidisciplinary clinic for SCN2A and SCN8A. And this has been, I think, 2 years in the making. Leah can correct me if I'm wrong, but it has been a long time coming as we waited for me to grow up and graduate fellowship and become an attending and just really get to put this clinic together. So I'm incredibly honored to get to lead it. I'm incredibly honored to get to see all of your kids, and just can't wait to show you what we've done and what we have planned. So with that, I will proceed forward. So this is a picture of our beautiful hospital in Denver, Colorado. And we are lucky enough at Children's Hospital Colorado to have an amazing space within the hospital just for multidisciplinary clinics. So it is a large space with rooms that are larger than typical exam rooms, so they can accommodate all the different providers you see. You get to stay in one room for your whole visit, which tends to be a half day, and have all the providers rotate through. So we know that your kiddos can be challenging and that it can be hard to move around the hospital and find different providers and find different rooms, and that's all a headache. And so we try to simplify that by having you guys stay in one room and we come to you, which is great. And the providers that rotate through the clinic include neurology and epilepsy, which is myself, rehab, which in this clinic is Dr. Werna. We have PT, OT, and speech therapy, We have both a geneticist and a genetic counselor that rotate through. We have a special care pediatrician, which is a kind of unique position at Children's Hospital Colorado. Other places may call them complex care pediatricians, but she's a pediatrician who specializes in complex care needs and is used to managing multi-system problems and can work through diet, nutrition, home, cardiology, and all of those systems and figure out kind of when we need to get specialists involved and how to coordinate and set up those appointments. So I really think she's a special and great addition to the clinic. We're also going to have developmental peds or psychiatry starting this summer. And then we have a neuropsychologist as part of our team who does a battery of assessments on patients before they come to the clinic and then is part of the clinic to discuss kind of the results of those assessments. And as I said, this is part of a larger effort by Children's Hospital Colorado to have a neurogenetics multidisciplinary program that also serves other conditions, including 8P, Ring 14, STX-BP1, a lot of different conditions that a lot of other physicians see and coordinate. But within that big program, I am the clinical director of this specific clinic, which is for SCN2A and SCN8A. And so the current plan is to hold one clinic per month, which classically right now is the second Tuesday of the month. And then there's an opportunity to have neuropsychology appointments the day before, as well as coordinate those special care pediatrician appointments, which I'll work through kind of how that scheduling looks in terms of clinic time for you guys. And so this is the structure. So there's a half day where patients, like I said, get to stay in one room. Families get to hang out and we all rotate through. And it typically is 8 to 12 p.m., like in the morning. And that includes myself and rehab and therapy and genetics. And then typically you see our special care pediatrician in the afternoon opposite your MDC time, though sometimes she's part of that rotation in the half day, just depending on her schedule. And then our neuropsychologist can meet with children typically the day prior or organize assessments kind of based on family schedule because she does such a good job getting a range of assessments, really takes time, picks assessments that are on the right level. And all that takes like 3 to 4 hours. And so it just can't be done within the clinic day. And so has to be arranged outside of that half day of clinic. But really think that those assessments are valuable, both in terms of natural history study, studying how SCN2A and 8A look over the lifespan, and also helpful in terms of bringing them back to school, bringing them back to therapies and saying, this is how we were evaluated, what should we be working on? And as part of those assessments, she always gives a list of things to work on kind of in each domain, including like speech and motor and those kinds of things. So I think is also a great addition to the clinic. And we also have a quality of life clinic that we can tap into if we want. Lauren Treat is one of our palliative care specialists and has been helpful in partnering with us in other multidisciplinary clinics, depending on patient and family need. And if that's something they're interested in, she's always helpful to join in. So happy to have her as well. And because that was a lot of words, I like a picture. So I just wanted to show kind of how a visit to our clinic could look. And so the day prior, you could meet with our neuropsychologist and do that kind of range of assessments. The next day, you would come to our multidisciplinary clinic and all of us would rotate through and see you. And that includes both clinical care and research. So I fully believe in kind of making the most use of y'all's valuable time, and travel is not easy. And so the hope is that we're able to provide value both from a clinical perspective and a research perspective. So we're seeing you, we're evaluating your kid, and then we are providing recommendations. So I generally give like a short list day of clinic, and then in the next couple of weeks, we kind of all get together and talk and create like a longer list of recommendations that can go back to your home team. And it's another important point, which is that we typically function as a consultative clinic where we see you every 1 to 2 years and provide recommendations that can go back to your home team. A lot of patients with SCN2A and 8A have seizures and complex care needs that you need boots on the ground wherever you live. And so we don't want to take that over, but we want to be a partner and a resource to whatever providers you're already working with. And so the goal is to not, take care away, but to be additive and be collaborative and give recommendations back to home teams. And so as we're all rotating through, we all hang out in kind of one central room as we're like going in and out of seeing patients. And so we're able to all talk. And Leah and Gabi can speak to this as well, that we kind of all talk as the day goes, like, oh, you already saw them. Like, what did you think? Like, what do we need to be looking out for? I really lean on my other colleagues to kind of be passing along like what we think we need to be concerned about, what are some, recommendations we can kind of all put our heads together about. And so we meet both before the clinic starts and then after the clinic's over to discuss the patients of that day and kind of what concerns were, what concerns got brought up, and how we can address them going forward. And I also think that's a unique aspect of our clinic is that we're all pretty collaborative and all willing to kind of talk and work together on what's best for the patient, which is great. And then our research coordinator is another piece of this. She rotates through during that multidisciplinary clinic time to consent families to be part of the research work that we're doing, as well as families SCN2A and International SCN8A Alliance. And so we're going to continue to partner as we go forward as new kind of research opportunities come up. And I think this is going to be a great place to learn about new research that's happening and new trials that are happening and how you can get involved. So we're doing both. The overall goal of the clinic is always providing really high level, exceptional clinical care, because I think that is the most important part and the foundation of what I want to do, but also to be engaging in research efforts to kind of furthering research for SCN2A and 8A towards clinical trial readiness and clinical trials. So we're trying to do both those things. And then either opposite that half day of clinic or within that clinic, you'll see our special care pediatrician who also does kind of an assessment of all the other organ systems that haven't been covered yet. Okay, that was a lot of talking. I have a few more slides, but I wanted to pause and just see if anybody had questions so far, or if anybody had anything that had come up about clinic flow or the providers that are involved.
Megan, we have a question. With the neuropsychologist, if we're already scheduled to be at the clinic, who would be contacting us about that appointment? Do we need to schedule that? If so, how do we get that referral?
Yeah, so if you're already scheduled in the 2A 8A clinic, I would contact Riley and I'll have her email somewhere in here. Yeah, there we go. So this is her email and this is her phone number. There was an issue with her phone number not having a voicemail, but I think that is fixed. And so email's probably better than her phone number, but I would email her and just say, hey, we're coming. We haven't heard about a neuropsychology appointment. It kind of sometimes depends on Andrea's, that's our neuropsychologist, is Andrea Miele. So it depends on Dr. Miele's slots, but if you're interested in a neuropsychology appointment, that's good for us to know, and I would reach out to her so that we can schedule it. Anyone else right now?
Dr. Abbott, since we're on neuropsych, just out of curiosity,
Yep.
if maybe we don't know if we need to see neuropsych, would that be maybe one of the recommendations from the team, and then maybe we could see them on a future visit?
Yeah, it's a great question. So if you're not sure if you need neuropsych and are unsure if you want to come for that kind of extra day for that, absolutely, we can see you clinic day and then recommend neuropsych in the future and make that appointment in the future. If you think it's going to be an issue to make it back to Colorado for a neuropsych appointment, we can always try to coordinate it for the same time as your visit. And honestly, most of the time, unless you've had one recently, think neuropsych testing is very valuable, both in terms of school recommendations, therapy recommendations, and to get a baseline. We use it in a lot of natural history studies as well, so it's good from a research perspective too. So it's my kind of like overall gestalt recommendation. But if you're not sure as a family and you're not sure if you can make it here kind of for 2 days, which I totally understand, then absolutely come to our clinic. We'll see the patient and kind of decide what we think is best. And we're also able, if it's not possible for you to come back and do neuropsychology assessments with us, we can always make that referral where you live and see if there's someone that can do the assessment where you live.
Megan, one more question in regards to the clinicians you have listed. Is there ever going to be more or less added? For example, GI, neuro, sleep, anything else like that? Because I know a lot of the kiddos experience different categories with that, pulmonary, anything like that.
Yeah, and so if we do have like a pulmonologist we can kind of lean on if we need him. And he's great and is in other MDCs. And I also know a GI specialist in other MDCs. It's not something that I planned on being a regular part of the clinic, but if you have concerns as a family and you're coming to our clinic and you say like, oh, we really need some pulmonary recommendations, or oh, we really need some GI recommendations, we can pull them into the clinic if that makes sense. I also rely on our special care pediatrician, Dr. Malik. Once she does kind of her full body assessment, she can kind of make a recommendation in terms of, oh, I think we need new pulmonary settings, or oh, I think like G-tube feeds, et cetera, need to be adjusted. And that can be helpful as well for knowing what referrals we need.
I think that's a good question. And I think you're right. Jessica's right. Like we do, so many of our kids see those specialists, but maybe the reason they're not part of this MDC is because they're more of like your everyday doctors. Like we need to have them. Oh, sorry, my dog's barking. We need to have them on our local team. And we come to you once a year for
Yep.
big.
Yeah, Leah, absolutely. I totally agree. Just like you need a neurologist on your local team, right? Usually if you have seizures or other things going on. I think pulmonary is especially important if you have a trach, if you have a ventilator and need those things adjusted on kind of like a week-to-week, month-to-month basis. But certainly if you're like, we're not happy with our pulmonary settings, like we have specific questions, we'd love a consult. We'd love input on, what another person would think. We're happy to try to coordinate that. It's just not something we think every patient needs. And so it's not something I've incorporated to be a part of the clinic all the time.
That might be something that when Riley makes those phone calls, she could mention, just because as like newer parents to this program, we just learned about special care at Colorado at Children's a couple of months ago when we could have been utilizing it for 8 or 9 months. So I know that as things come up, sometimes we don't even think like, oh, we probably do need pulmonology. So I don't know if there might be just a little checklist that they could run through and say, hey, do you already have these services or do you think you need them? I know some people might check all of the boxes, and I'm sure there's a way to make it work, but that would be a great resource just to know, hey, you don't have just this for the clinic. There are additional options if you need them, kind of thing.
Yeah, absolutely. It's a really good point.
It might be a good time to segue into talking about the pre-visit data collection that you all do and how people can say, well, you ask families what their pain points are, right? So then
Yep.
it kind of pulls in, at that stage who you might need to pull in.
Yeah. So as part of our intake process, Riley, our nurse coordinator, sends out a pretty extensive survey, which I kind of apologize apart, but kind of feel like is necessary for all these things that Jessica brought up, which is that it goes through kind of each system, this intake questionnaire, and lets us know kind of what concerns are, what's missing in terms of care plan, what gaps parents see. Goes through kind of each system in terms of pulmonary, GI, vision, different therapies, what you're getting, what you're not getting, what your major concerns are coming into clinic. And we have a pre-meeting actually of me and some of the core providers in the clinic, usually the week before clinic, where we try to go through those surveys. So when Riley sends you an email saying that we need the survey done, you're like, hey, we're not being seen until next week. Like, why do you need this giant survey done already? It's because we're doing our pre-meeting. And it's helpful to us to review it ahead of time for exactly these reasons of like a week out, we can be like, oh, they really said they needed, this and this. Like, can we make that happen? Can we try to get that person there in the clinic? Or can we set it up for after the clinic? And so those pre-surveys are kind of vital to us, even though they can be lengthy and hard to do as a parent. But I thank you in advance for doing them. And I think it really helps us kind of highlight what kids need and then what to address day of.
Can I ask a question? Sorry.
Of course. Sorry, I
Jump up
can't
in.
see
Yeah.
everyone, so I don't know who it was.
Oh, here, we can, do you want to stop sharing and then we can have
Oh,
the screen? And
yep.
that way maybe, and I put the information in the chat so that people
Oh.
can.
I'm sorry. Can you hear me now?
Yes.
Okay, I think I pressed something. Sorry. Besides the survey that you send, what kind of other information would you need in terms of, like medical history? I think, like for me personally, every time we see a new doctor, this is like my biggest fear and struggle, like trying to explain the last 8 years. Um, so is there like any other, like information that you need before we see you at the clinic?
Yeah, absolutely. It's a great question. And everyone hates going to the doctor and having to re-walk through the entire history and kind of go back through everything you've gone through, right? You hate doing that 100 times. So ideally, Riley and we have kind of a nurse assistant who helps her, Ruth. And so they try to coordinate getting records from wherever you were seen before and get them uploaded before your visit so that I have time to review them and understand what's going on. So they generally help coordinate that, and then we'll let you know if they need things signed or need like a release signed and those kinds of things. But a lot of places, the electronic medical records communicate with each other, and so we're able to get things pretty easily, but sometimes it can be difficult and we'll work through those hiccups. But the idea is that we have a lot of information before we see you in the clinic so that we're able to kind of start with where you are and provide recommendations going forward, not spend the entire time walking back through history if we don't need to.
Okay, thanks.
Yeah.
So I have a question.
Oh, me too. Sorry.
I think I saw Daniel first.
Okay, sorry. Oh, yeah, sorry. I'm using my husband's Zoom.
Yeah, I figured.
I'm Carrie. I'm June's mom. And so we've done we've been really lucky. We're at Cincinnati Children's right now, and we've done a battery of tests with a lot of these different specialists you've been talking about. And so what I feel like we're lacking or I'm lacking is one doctor who knows what SCN8A actually is and kind of like a trajectory and understands that
Yep.
it's a lot more than just like seizures or her
Yep.
ataxia or whatever. And so would this be like a good fit that like once a year we would be able to come in and do a check-in and you guys would be able to kind of, along with her team, continue to kind of give better guidance to them? Because we had an appointment with her ataxia neurologist last week, and I was telling him about the Facebook group and how they kind of helped me capture or understand what a focal unaware seizure was. And he told me, that that's the best place to learn, and he's still learning. So like, he's great, but I don't love hearing that he's still learning about what he's treating her for. So like, if there is somebody who actually knows and like that's what they do, we would love to figure out a way to come.
Yeah, I think that's the goal, right? Is that while we're not going to see you on, a month-to-month basis to manage seizures, the goal is that you come once a year, check in, and everyone knows what SCN8A is. That's the beauty of it. You're not having to be like, she has SCN8A, this is what that is, this is what this means, and then she has seizures, and then you narrow in on seizures, right? That's what a neurologist typically does, or you narrow in on lungs, or you narrow in on muscles. But the goal of coming to the clinic, the multidisciplinary clinic, is that we're kind of all centered on she has SCN8A. What are the manifestations of that? What is that going to look like going forward? And check in on that, right?
Yeah, that sounds great.
That's the goal. And so that's honestly, like you just said really beautifully, the dream and the vision of the clinic, which is that there's someone here once a year who knows what your kids have and is able to speak to what do we need to do clinically to manage SCN8A? What can we do from a research perspective to learn more? And like, where are we heading? Like, are there treatments coming? Like, what does that look like? And so we're hoping to be a hub for all of those things.
And if her treatment team like had questions in between, they would have access to you guys to kind of run ideas by you.
Yep. I talk to people all the time on the phone. I'm happy to message. I'm happy to email. I'm very accessible. I think the goal is to not, yes, we see you only once a year, but like once you're with us, like you're part of the family. Like we're a home base, and we're happy to talk to home teams and walk them through kind of what SCN8A is and what we think a good care coordination strategy is.
Oh, awesome. All right. Thank you.
Yeah.
See you, Kara. I just want to jump in and share too that I think what you get with a team like this is a group that understands SCN8A and SCN2A. They know about it. They've seen a lot of the kids. They read the articles. They've read the consensus. They talk with our researchers like Michael Hammer and with other clinicians. You know, we have several multidisciplinary clinics, and so it's also getting those teams talking to each other. And other clinicians, like we have an SCN8A clinicians network that's coming together. And so those will be places where they can come and learn and share difficult cases. And so, and 2A has, you know, parallel things as well. So the beauty is that these are people who really care about these disorders, really read all their articles, learn everything about it, are engaged with our foundations, and people that frankly come to us too. Like, you know, we were sitting in the room between seeing patients and they're like, is this something you see or hear about in the community? So they know that our groups know a lot more than some before clinicians do, right? Before it gets published. So they also rely on us as teams to help them see what's emerging, and then they can start looking at it and doing research on it. Like, oh, we're starting to see a lot more of, you know, early onset puberty. Like, are you seeing that? What does that look like? So all that kind of stuff. And I just think you did say it beautifully. And I would be so excited to get you out there to see, and June, to see this team. They're really awesome.
Oh, yay.
Yeah, it'd be great.
So just
Yeah.
grab that email from the chat and you can email them and get on the calendar, I think.
Yep. Yeah.
And you guys also help figuring out insurance. So there's other elements that come
we
up in the
haven't hit that
process.
yet.
Yeah, so maybe that's a good thing to chime in
Yeah,
on.
so I think a question I get a lot is, what about insurance? What about out-of-state Medicaid? And we've had a lot of success getting out-of-state Medicaid approved. There's a couple of states that are a little bit more challenging for us. And so, sorry, that's my 4-year-old walking in. I just got distracted for a hot minute. But usually we're able to get out-of-state Medicaid approved. Insurance has not been as big of a barrier as I thought it would be for getting patients into the clinic, and we help work through that. So Riley and other people within Children's Colorado help work through insurance issues before you come. And if anything comes up, of course, we'll let you know. But typically have been able to work through most issues. I will say I think California has been an issue, but maybe has gotten resolved recently. So TBD.
And it's great because they do the fighting for you. So
yeah. The goal is that they're doing the communication and putting in the prior auths and whatever needs to be done. And so I know insurance can be a huge headache, but we try to handle it as much as we can for you guys. other things I wanted to say is that, yeah, I guess I mostly wanted to highlight that not just myself, even though I lead the clinic, but other providers in the clinic, our rehab physician, our special care pediatrician, they're not just like stopping into 2A, 8A clinic for the day. Like they're all in. They've been reading articles. They, are coming to conferences this summer. Like we're all going to be at the conference this summer for SCN2A. And, we're just excited and interested about seeing your kids, learning more, trying to provide as much guidance as we can. And so it's just been really cool and is a nice collaborative team to be able to see SCN2A and 8A patients and keep learning along with you guys as new research and things come out.
I have a question. This summer, so we're having our conference this summer in very end of July, beginning of August, and 8A is joining us for the first year, and then we're going to be doing it more and more over the next few years. And I know that you're doing a special clinic for the conference, and there's very limited spots. But for those spots, will the neuropsych be available?
Yes, I am still working through what her slots look like for that.
Okay.
So I do not know. So for the clinic before the and I apologize. I didn't know it was an official 2A 8A conference, so I will call it thus from now
No,
on.
it
Um,
isn't fully, but we're working on that. That's our goal.
We're
okay, sounds
transitioning towards that. Yes.
Okay, sounds good.
Yeah.
But for the conference, there's going to be a clinic July 30th, the day prior. And there is 6 slots in the clinic, and I do not know if I'll be able to get 6 neuropsych slots. So I'm working through how many neuropsych slots we can have. But my hope was at least to have 2 or 3.
Perfect. Thank you.
There
Yeah.
was also a question maybe we can pick up on in the chat too, which is what is the right age to start get neuropsych? I don't know. I mean, people probably have different opinions on this, but just in general, do you recommend that people do that, start early?
Yeah, I honestly think she's done as young as 1. I think typically like 2 or 3 is great. Age 2 or 3. We generally like age 2 or 3, school age, like 5, 6. And then every couple years to help with school learning plans, therapy plans, things after that. Um, but I honestly don't know or don't think that there is like a too young. I, I think she has done a 1-year-old before. So, I would defer to her on that. I'd have to ask her, but I think probably sooner is better.
Yeah. And what I've heard from other neuropsychs too is this idea that if you're starting to see that they're falling further and further behind, right, then it's clear that there's a need there, and getting in is because sometimes it takes a while to get in with a neuropsych, and then the testing, and then they have to analyze everything. And so, yeah, I think that
Yeah,
makes sense.
absolutely.
I'll double check the chat to see if there's anything else in
I don't
there.
see any questions in the chat. While we're waiting for other questions, I was wondering if you could give us a little bit of an overview of the research. We all love research and participating in research and moving it forward.
Yeah. Does anybody mind if I share my slide again?
Oh, please.
Okay. I mostly so from a research perspective, I will say both that we are working to collect essentially natural history study like information, right? So we're collecting as a group information about developmental milestones, exam, um, you know, different neuropsych measurements, and then plan on partnering with Families SCN2A and International SCN8A Alliance with their data collection as well. For instance, I know SCN2A does data collection through I Am Rare, and the plan is to kind of partner on those things, and that we're able to kind of connect you with those databases through the clinic. I did kind of want to speak to just a personal passion of mine and research that I'm planning on doing through the clinic, if that's okay, if people will indulge me, which is outcome measures. And so I am particularly passionate about being able to measure small, meaningful changes in neurogenetic conditions in general, but in SCN2A and SCN8A, with the idea that gene therapy, ASO trials are here, right? They're not far away. And people are still, using seizures as kind of the benchmark for if a therapy works. And not all of SCN2A and SCN8A kids have really bad seizures. Sometimes they're well controlled. Sometimes they're well controlled and then they get worse and then they get better again. And so is this the best outcome measure that we could be using to see if a therapy is working or not? And I think it's really important to measure kind of small, meaningful changes and learn kind of how we can measure those things effectively in a clinical trial. And so as part of this clinic, I'm looking at clinical severity assessment measures, trying to find out if a measure could work that can measure multiple domains, including like communication and motor functioning. And so I'm using a measure, I'm using a measure that was previously created for CDKL5, which is another genetic epilepsy. And they made an outcome measure that has all these different pieces kind of put together. So communication, motor, vision, seizures, behavior, autonomic functioning, all of that's included within this like CDKL5 clinical severity assessment. And sorry, we're getting a little nerdy and sciencey for a second, but I promise I'll bring it back around. And I think the great thing about this assessment is it's a really easy assessment for both providers and caregivers to do. And so I do some of it in the clinic when I see kids in the SCN2A and 8A clinic. This is just an example of a motor item of like, how is head control? How is getting from laying down to sitting? And so we ask some of these questions, which are just part of a neurologic exam, but we're doing it in a structured way that produces a score that we could potentially track over time. And so I started piloting this in the clinic as a resident and a fellow before I had the chance to start my own clinic. And so these are just some of the conditions that Dr. Demarest had seen before me. And so we started piloting the score in those conditions, and it works well to kind of capture a range of severity across a condition. And this just shows the different domains. And so the clinician score that I do is motor, communication, and vision. The score that we send out to parents, which is just if you come to the clinic and you consent to research, then we have kind of a battery of parent-reported assessments we send you. And this is one of them. And so you fill out kind of a questionnaire, which we appreciate. We know questionnaires are not an easy lift all the time, but it has 4 domains, including seizures, behavior, alertness, which is kind of sleep questions, as well as how alert you are during the day. And then autonomic questions, which includes GI functioning as well. And the goal is to study this scale. This is my primary kind of research interest. We've been talking a lot about my clinical interest and how we've set up the clinic, but I have a research hat as well, and this is what I'm doing research on, and actually have a grant from SCN2A to do research on within SCN2A. And the goal is to see, will this scale work in terms of being able to measure small changes in future trials. And then my other pet project is something that we haven't talked about yet, which is something we evaluate for in this multidisciplinary clinic, which is cortical visual impairment, which has become near and dear to my heart because as a fellow, I realized that not a lot of people were diagnosing this or providing resources. It's something that ophthalmologists think is a brain problem and a lot of neurologists think is an eye problem, and we just play volleyball back and forth across the court. But I luckily, like I said, got to be trained by great people who were also interested in cortical visual impairment and taught me how to evaluate for it and taught me assessments to do to test for it. And so it's a crucial piece of your neuro exam when you come to the multidisciplinary clinic. And just to give some background, so cortical visual impairment in general, the definition is visual dysfunction caused by problems with brain, not problems with eyes. So your ocular structure and function is intact, but there is a problem with visual processing. I always do it as a corollary to sensory processing because I think sensory processing has gotten a lot of buzz and a lot of press, and people understand, my gene, my SCN2A gene is not working properly. And so my nerves don't work properly. And therefore I have seizures, I have motor challenges, I have speech challenges. I can have sensory processing challenges, right? We know that. You can also have visual processing challenges, which is what I think cortical visual impairment is in this population. And so it's now the leading cause of pediatric visual impairment in the US. And just some symptoms of CVI that people may not realize is increased attention to bright lights or certain colors like red, decreased visual tracking, using your peripheral vision to look at objects. So patients with CVI will kind of grab for things like this and not be like looking and grabbing, kind of grasping for things, difficulty walking over surfaces, like changing from carpet to wood or going over stairs can be really challenging, and difficulty with busy environments. So needing kind of a simplified black on white, visually striking background is usually helpful. And so in the clinic, I generally screen for CVI by asking some of those symptom questions. And even on that initial kind of pre-clinic survey you get, there's a whole section on vision. And then within the clinic, we use screening tools like the clinical severity assessment, which has a visual domain that I do assessments with. So I look at tracking, I look at eye movements, and then I look at something called an optokinetic nystagmus reflex, which is a really big word, that essentially is how the eyes are doing at tracking lights. And we literally use an iPad to do this kind of test. And it lets us know how well the eyes are seeing and how well they're tracking. And so putting all of these things together, both the history and the exam piece, we can have a good idea on whether or not someone has CVI. And the only thing I would say is that it is helpful if you've already had an eye exam by an optometrist or ophthalmologist. That lets me know that the eyes are, the vision is corrected in terms of does the patient need glasses, that there's not some underlying kind of ocular or eye abnormality that would make seeing difficult. And if you've had that exam and then I do my assessment and I think you have a diagnosis of CVI, I will give a diagnosis of CVI within the multidisciplinary clinic. And we can provide a lot of resources in terms of taking that back to home teams and what that means for therapy plans and school plans and what you would qualify for in terms of educational services. A huge part of giving a diagnosis of CVI is that once you know you have a diagnosis of CVI, you actually qualify for a lot of things within the educational system, including a teacher of the visually impaired, which I think is really important and a lot of people don't know. So it's one of the reasons why I'm passionate about looking for it and not missing it within the clinic. All right, thank you everyone for indulging me in my two kind of big research interests. Questions on that, I will pause.
I have a question.
Yeah.
Hi, sorry. So my daughter Lilith, she's 14 and she actually goes to Children's Colorado. So she's a patient of Dr. Nups and all the other people there. I'm super excited about this. So because she sort of she's got other genetic things too that go along with this, but SCN2A has been one that's always like, knowing the group, I've known Leah and all of them for a very long time. So she coordinates the most, I should say, with those, with that particular gene. And so with the CVI, sorry, I'm actually gonna indulge you on that one because I am super excited about this one because I went to the conference for the first time, the SCN2A conference this fall in California, and she did do one of the CVI testing, and that person kind of like it was. I think it's because she was not in a place of going through the test that she kind of didn't. She's like, well, I don't think she has it, but I'm not really sure. And it's a lot of it was her participation because she's an interesting little creature, and and which I am excited for you to meet. No,
Excited too.
but I took that back. She had an ophthalmology appointment. She does have glasses and things for other stuff, but afterwards, and I kind of told them what we've been seeing because, like, her speech therapist and I noticed that she cannot see no matter what. It seems like out of that right side of her, just peripheral vision, like it doesn't matter. You can put letters in front of her, she will figure out the other letters. She will miss that same letter every single time. And it's really like affected her learning, just her memorizing things, figuring out words, because like she's not even seeing it. As soon as she gets to that other side, it's like it's gone. I mean, she runs into walls on that same side. You see her when I love when you're talking about different surfaces and stuff, because we've noticed that her whole life. And so I was like, when I went to the one testing, I was like, oh, I thought for sure, because her speech therapist and I was like, I think this might be it, you know? Well, when she was taking her regular ophthalmology test, they started noticing when they were doing the letter charts for her to see how far she could see, that every time she'd get to that side, she'd miss it. And it'd be a letter that if it was on her left side, she'd get the letter right away. But if it was on her right side, she'd miss the letter completely. And it was just those far right sides. So I am just saying I am super excited to do this testing with you because it really it's really just been I feel like a big hinder in her life because she hasn't got the proper services. And even her ophthalmologist, she actually said that we should try to find somebody that does like visual therapies or something for her because she agreed that she believes that she does have the CVI. Um, I'm also excited just to work with you in general because she's a fun study.
I'm excited. Yeah, I'm excited to meet her and you. Yeah, and I just think, evaluating for it and giving the diagnosis are so important for getting services. So thank you for highlighting that.
Yes, I like that. And I also do like that you were talking about the little changes, not just like based on seizures or whether they're not having seizures, because I've always based her on that because her seizures kind of go back and forth, back and forth, back and forth in severity. And whether she's on the same thing or not, it just so many things change. But then there's other advances, it seems like in her cognitive function. Well, we might have big advances in the cognitive function, but then all of a sudden we have a bunch of seizures. And then, we're still advancing in those cognitive areas despite the fact that we're having seizures. So I never really judged it on that. So I do like the way you're looking at that. And I just so I know you're talking about obviously most of the people that don't necessarily live in Colorado to go back to their teams. If we do there, is that something like that we can see you guys as some of her primary doctors if we make that choice?
It's a great question. I always tell people I'm not in the business of stealing patients, but and so if you have a neurologist or you have a special care pediatrician or you have a rehab doc at Colorado that you like, you don't have to worry about coming to our clinic. And I'm like, no, you have to see us now. But that being said, if you come to clinic, you like providers, you're absolutely able to kind of switch and see people if that's kind of what you deem you want. I do think there are rules within clinics about how much you can switch providers and that kind of stuff. So some of that gets a little political, but we can try to sort through those things. In general, I think in neurology, you're allowed to switch providers once. But I'm also willing to talk to providers. So you can see me once a year and I can keep talking to whoever else you're seeing on a more regular, like every 3 to 6 months basis too. So there's lots of options, whether you live here or live afar. I'm just trying to be kind of collaborative and helpful, and however that best works out is how I want it to be.
Awesome. Thank you.
Yeah.
I thought maybe we could mention one more thing. So you talked about being like a place where people come every year or two, and they have their home team. You've talked about that last question was, yes, you can be a primary.
Yep.
And then the last option is that you can also be a second opinion site, right? So people can come if they feel like they don't know what's going on. They want somebody who knows SCN8A or SCN2A, and they want to just get a second opinion about the status of their kid. People can come for a single visit if they want as well, to just kind of be seen by somebody and get kind of confirmation of other issues that they're having.
Yep, 100%. So, happy to kind of provide updates on recommendations, or if they want another opinion about what's going on, no matter what system we're talking about, just happy to provide that as well. So yeah, I think it's a good summary that, happy to be a consult for home teams back home, happy to be provide an alternative opinion if you guys are struggling with something. And then if you live here and don't have a provider, your provider has moved or whatever the case may be, also have taken on people as primaries as well.
And I'll pull in one more question that I got from another family who couldn't make it, which was, do you write prescriptions? And I think that's an important one to have some clarity on. Yeah.
Yeah, no, it's a good question that I usually forget. So I appreciate it. In general, if we're talking about our most common scenario, which is probably the consult where I'm providing a list of recommendations and you're taking them back to your home team, I don't typically write prescriptions because I keep using neurologist because that's my background, but for your home neurologist to write a prescription so that they're able to manage refills and kind of know doses and that kind of thing. However, if it's like a long time before you get into your neurologist, or you need the medicine that weekend, and I absolutely have written prescriptions for families, so it's not a hard rule. It's just, in general, probably best for home teams to be ordering prescriptions and me to be providing recommendations. Another caveat to that is if you're my primary patient in Colorado, then also I will write prescriptions, of course.
There was a question I forgot about in here, but thanks to Alexandra for putting in here. Do you foresee any complications with Canadian patients potentially participating in research or studies? And would consulting with a care team in Canada potentially be an option too?
A couple of things that come to mind when I think about international visits, and even though Canada's right there, it's still like considered an international visit. International visits in general are cash pay for our clinic. And so we can work through what that looks like in terms of Riley has like how much each provider costs from a cash perspective and what that looks like putting it all together. But I'm absolutely happy to talk to providers in Canada if people need opinions or need help. And certainly if we saw you in clinic, happy to talk to providers afterwards as well. It just the insurance and payment can be an issue. Yeah, and I'm looking through the chat too, sorry.
And it sounds like it's always a good idea to just check in with Riley. Riley knows a ton. She's amazing. So
yeah,
just write
Riley's
Riley.
great. And Riley wanted to say sorry, she cannot be here tonight. For the record, she is like imminently having her second baby. So there are plans for that. So someone will answer when she is out for the next couple months. It will be a different nurse coordinator whose name is Tristan or Christina, and they're both great. So our clinic is not being left just temporarily by Riley. But there's a plan to still kind of get patients scheduled and answer questions. And Tristan has been doing this a very long time for the Rett Multidisciplinary Clinic, so is very experienced and has offered to help out in Riley's absence. So
we send our best to Riley.
Yes, will do.
Megan, I don't know if this is jumping the gun if you had finished the presentation portion or not, but I guess as a parent or a caregiver, what should we have in terms of expectations with walking away from the clinic? What are we going to have in hand from you just so we can manage to our expectations? And just kind of what is our homework going to be going home and talking to our providers there as well?
Yeah, so I hope going home from the clinic is we generally have like a short, what we call after visit summary from each provider that saw you, which is just kind of a short summary of recommendations from the day. And then once, we all put our heads together and have our post meeting and finish our notes, you'll get all of our notes, which ends up being kind of a long packet of recommendations and assessments. And so once everything's said and done, you'll have all of our thoughts and exams and assessments. It can just take a week or two after the visit. And ultimately, my hope is that you walk away from the clinic feeling seen, like you saw people who know what SCN2A and SCN8A is, that you have some core ideas of things to take back to providers or therapists, of things to work towards, or, no, things are good and these are things that we think we should do in the future. And that, that you have people you can rely on if things come up. And so, other than an after visit summary and those kind of less concrete things, are there things, this is good for me to learn too, are there things that you would hope to be walking away from the clinic with, or action items that you're
Yes, I would
hoping?
love to have seizure free. I would love to have head control. I would love to have no GI. No, I'm kidding. But I do think that
Yeah,
one
definitely.
thing that we struggle with, and I mean, we're here locally as well. We have Dr. Bonds and we adore her.
She's
But one thing she is, and thank you for being her awesome mentor. But one thing we struggle with is just the next step of everything, right? So especially for families that might be out of state, out of country, that are going to be coming in, that might not have the closer connection to children's, there's that concern of, okay, so we understand we're at this point in our seizures, but what happens in 3 months if we regress and we need to do a medicine change? How do they go about getting that information? Is that going to be a tiered program of like, okay, here's where in our theory, the next 3 medicines we would suggest would be, would that be something you would provide and just kind of outline for the patients? Because I think we're more than willing to give you as much information and data on our children as possible. We just want to walk away with the idea of, okay, because we see GI out of children's, this is what we would take back to the GI. And instead of having to come back to you every couple of months with questions, we could say, okay, that didn't work, on to plan B and move on from there.
Yeah. I will speak to seizures because that's what I know the best, which is that in the clinic, I generally lay out my overall rationale for seizures in terms of what I think about, number of meds and how to add meds and how to take them away. And I think and hope that that provides value just in terms of management. Like this is kind of how I think through seizures in SCN2A and 8A. And then I generally, based on a patient's like med list, give steps 1, 2, and 3 of what I think some next options could be. And if seizures continue at this frequency for this long, would try this, would try this, would try this. Because I agree, you're only seeing us once a year, and I think it's really important to walk away with contingency plans. And that's not just true for me, that's true for therapies and rehab and GI nutrition plans, those kinds of things. It's nice to have contingency plans. So we tried to do that for sure. Yeah, I'm reading the chat and I think it's such a good point. Which is, can you speak to loss of function non-seizure kids and the expertise you can provide for them? Yeah, 100%. And what I would say is that in terms of loss of function, gain of function, I think some of the expertise we provide in general is knowing that knowledge, like going into an SCN2A 8A conversation, we've looked at the variant, we kind of understand phenotype and are able to talk in terms of, do you have gain of function or loss of function? What does that mean for medicine choices, for trajectory and, where we think development, what do we think development's going to look like? What do we think behavior is going to look like? And so I think that's a plus of the clinic. But specifically, for sure, seizures are but one very small wedge of a giant clinical picture that we are both serving and putting together in terms of the clinic. And so I think a real asset to the team has been our rehab doctor and specialist, Dr. Werner, and he is great at not just he really does so much more than coordinate therapies and understand therapy assessments, PT, OT, and speech, but has done a great job helping me co-manage sleep and behavior as well. And so we talked about behavior. We talked about how's behavior going at school, how's behavior going at home. Can we talk about meds? Do we need behavior med management? And we do behavior med management, or provide at least recommendations for behavior med management within the clinic. We do sleep. So talking about sleep, willing to provide recommendations or even write prescriptions for, strategy for sleep medications, if that's where we're at and what's needed. And then in terms of our developmental assessments, obviously Dr. Miele is doing a whole battery of like developmental and neuropsychological assessments that would be important for kids with loss of function, SCN2A. And come this summer, should have a developmental pediatrician and or a psychiatrist within the clinic to be helping with both behavioral management, sleep, and developmental assessments as well. And I think they should be onboarding in July or August, which is exciting. And then, oh, and autonomic. Yes, absolutely. So I assess for autonomic functioning within my portion of the visit, and can talk through some of those concerns as well as strategies for mitigating things. And certainly that would be true for kind of kids across the spectrum with SCN2A.
It's so refreshing to hear you say that you're willing to talk about autonomic, assess for autonomic, CVI, all of the things, because so many times as a parent of a complex kiddo, we get you don't fit into my box. It's not a seizure. And so then what is it? Is it a movement disorder? And that's where we stop. It sounds like, and I know already, but your team is just willing to not stop there, and not let that be the end. So I'm so grateful for this clinic, and I on behalf of our entire community, thank you for starting it, and we're so excited to have you on our team.
Yeah, I mean, honestly, this has been a dream of mine. I'm very excited. And this is a realization of a lot of really cool, smart people coming together to make it happen, including Gabi and Leah. So I'm just very thankful that all of you guys are willing to be here and let me see your kiddos and patients. And I just, can't wait to meet all of you.
A lot of love in the chat too for you. I think this is the thing we dream of, and that's why we're so grateful, is that we have clinicians who understand our disorder as best as they can. We know there's still a lot to learn, who are interested in doing critical research to help us get closer to better treatments and listen. I think that those are like 3 key elements for our community, and we know you're doing an amazing job. We saw it on day 1 and look forward to continuing to see that. So I echo everything Leah said, and we're so excited for this, and I'm sure we're going to have you booked up pretty soon for the rest of the year.
Yeah, we'll book slots pretty far out. So email or call, and we're excited to get everyone scheduled into the clinic.
Thank you for taking time to do this with us tonight, Megan.
Yeah, of
And thanks
course.
everybody for joining. And thanks to Leah for being an amazing partner in this work. We're really going to learn a lot together.
Have a good night. Thank you.
Take care, everybody.
Thanks, everyone.